All right. Good morning, everyone. Thank you so much for having me here. Let's figure out if I can use this thing. I can. So I'm delighted to be here today. Thank you very much for the invitation. I'm here from Quebec City in Canada. Canada is quite large, so I'm going to zoom in so you can see where it is. Quebec is an Algonquin word, which means where the river narrows, and it is the traditional territory of the Huron-Wendat, Abenaki and Wabanaki Confederacy, the Wolastoqiyik, and the Haudenosaunee peoples. And it is a long-standing site of trade. It was used for thousands of years before anyone from this continent ever stepped foot there. It's a lovely place, and I encourage you to visit if you ever have the chance. However, if you come in winter, make sure you are ready. There's a lot of snow. So my declarations, I'm always very aware of the fact I'm going to be presenting recommendations that are drawn from a variety of different projects, our own work, other people's work, and I'm just always very conscious of the fact that the organizations and agencies who give us funding influence the way I think about things and the kind of work I do, so I'm very grateful for that. I don't have any known financial conflicts of interest. However, I do have a known personal conflict of interest, and the very first talk yesterday introduced the concept of continuous glucose monitoring, which I personally use. I've lived with type 1 diabetes since I was a kid, so you can see the Dexcom on my arm there with my youngest there. I'm wearing it right now, although I don't have the really cool superhero sticker around it. Those are just for fun once in a while. My colleague in Ottawa, Sylvain Boet, always says that research is a team sport, so anytime I'm presenting, I like to give acknowledgements to my team. I feel very privileged to work with such a wonderful team of students and staff. I'm very grateful for them. And today I'm going to be talking about some data. A lot of the data I'm going to be talking about are drawn from a project that was funded by the Agency for Healthcare Research and Quality in the US. And the principal investigator for that project was my colleague Brian Zygmunt-Fisher, who's up on the top left here. These are the other members of the team. And so I just want to also call them out because this was very much a group project, and it's an interdisciplinary kind of work. And so you need people from all sorts of different fields. So Brian is a behavioral economist by training. Angie and Aaron, who come next, they are both psychologists. Jacob is from human-computer interaction like me. Then we have a bunch of clinicians who bring their clinical expertise to this project. So my background, I'm going to present what I do a little bit because it'll make the recommendations a little more clear where I'm coming from and why I'm suggesting these things. I'm an engineer by training. My undergraduate degree was in mechanical engineering and mathematics. And then I worked in engineering for a few years in industry before going back to grad school, and I did my PhD in what's called human factors engineering. And human factors is the study of the interactions between people and technology. And the way I talk about it is it's about designing for the way people are instead of the way we wish they were. Or another way to think about it is adapting systems to people rather than expecting people to adapt to systems. And I do this, so essentially I'm a methodologist. I have these methods, I have research questions that are related to these methods, and I use these methods in a variety of applications, but all around the sphere of health education, communication, and decision-making, including shared decision-making, which is a very specific thing. And my goal really with all my research is to help people make evidence-informed, values-congruent decisions. So evidence-informed means that the decision is informed by the best available scientific evidence, and values-congruent means that it's aligned with what matters to the person. Because two different people may be faced with the same medical or the same health situation, and they may make quite different reasons because different aspects of their options matter differently to the different people. So the kind of work I do, I have a human-computer interaction lab. This is me and some of my students in my lab. We do eye tracking, galvanic skin response, which is a measure of emotional arousal, so how strong of emotions are you feeling. We have a webcam and software that helps us analyze facial emotions, so that gives us emotional valence. Are people having good, positive, strong emotions, negative, strong emotions? And an EEG, which we use for cognitive load and engagement. And it gives us stuff like this. This is one of my PhD students' projects that she's working on right now, Hina Hakim, and she's doing a project about how to help people better understand how herd immunity works. So that's the kind of stuff we do. So what does this have to do with clinical chemistry and laboratory medicine? So just to wake everyone up a little bit, it's awfully early. I feel like I'm from North America, so it's like 2:30 in the morning as far as I'm concerned. So I'm going to give you all a challenge. I would like you to guess the decade of this quote. This is a quote from a paper. The clinical interpretations of a laboratory finding should be given only by a registered medical practitioner. So you don't have to say it out loud, but think to yourself, what decade is that from? And the second one, direct notification of abnormal test results would result in patient anxiety and confusion. Patients lack the necessary expertise to interpret test results. So just reflect for yourselves. When's that from? Everyone ready? Everyone awake? Okay, we're still good? Okay, so the first one is from almost 50 years ago, and this was in reference to the introduction of home pregnancy tests. That we can't possibly give people tests to see whether or not they're pregnant at home. The second one is much more recent, and this is a survey of emergency room physicians. But as we can see, a lot of the concerns haven't really changed. It's just that our expectations of what we think is normal changes. I don't think anyone now would suggest that we shouldn't have home pregnancy tests. That's no longer an argument. But we are still having the argument about should patients have access to their own test results? So there are valid concerns about people's understanding of laboratory test results. But I'm gonna bring an idea from my field. So this is a quote by Brett Victor. This is from an interview with Brett Victor. And Mr. Victor was one of the first employees at Apple when Apple was developing the iPad. So he was part of the team that figured out, they had this new hardware and they figured out what they were gonna do with it and how they were gonna design the interface. So he says, the example I like to give is back in the days of Roman numerals. Basic multiplication was considered this incredibly technical concept that only official mathematicians could handle. But then, once Arabic numerals came around, you could actually do arithmetic on paper, and we found that 7-year-olds could understand multiplication. It's not that multiplication itself was difficult, it's just that the representation of numbers, the interface, was wrong. So these are my own lab results. I will suggest to you that this interface is wrong. I'm a relatively bright person. I have lived with type 1 diabetes since I was a little kid, so I have decades of experience. I speak French, so I can read the French, and I can mostly make sense of this. But if I were new to this, I think I would have a lot of difficulty with this, and when I see test results that I don't know, I have to look them up, I have to talk to my physician, I would suggest to you that this interface is not optimized. This interface comes from a paper that Brian, myself, and Nicole Exey, who's one of the research associates at the center where Brian works. We published this essentially to look at, do people understand their own test results when they're presented in tables? So this interface is taken from the EPIC system. EPIC is one of the major electronic medical records vendors. And this is what the University of Michigan uses. So this was taken directly from, this is how things are presented to the patients who get care at the University of Michigan. And what we found was that no, in fact, this interface is not really optimized either, and people have a lot of trouble making sense of it and figuring out what all of these things mean. And this is particularly true for people who have low health literacy or low numeracy. And numeracy means your ability and your confidence with numbers. So this is from about 5 years ago. The US government ran a contest to redesign the electronic health record. And this was the winner. This was the team that won the best overall design. And so here I think we're getting a little bit closer to an optimized design. There are still a number of problems that I can see in this interface, but we can see we're getting better. Having said that, as far as I know, nothing that they're showing here has been actually tested, and as far as I know, it's not, these concepts are not implemented anywhere. So, a little bit of information theory. In information theory, we distinguish between data, information, and knowledge. So data are symbols. Information is symbols with meaning, and knowledge is information placed in the context of existing knowledge, and it's actionable. All of this is in the paper, by the way, but I'm happy to share slides too. So the central premise here, the central premise of our paper is that laboratory results are data, but what people need is information and knowledge. And so systems that we use to provide laboratory results directly to patients and families need to help people turn data into information, into knowledge. So we have 10 recommendations for how to do this, drawn from our own work, drawn from the literature. So the first recommendation is, whenever possible, provide a clear takeaway message for each result. People don't necessarily need all the details on the first go. And we'll talk about that a little bit later. But basically, most people are coming to check their results with one or two questions. Am I okay? Do I need to do anything? And so the system, the way we present the results, should answer those questions for those people. And on the right, you see an image from one of the papers that we've published from this work, where we showed that using the number line, so any of those 3 number lines below the table worked much better than the table. And we'll talk a little bit more about, which of these ways to do it. But basically, this result is a little bit below the standard range or the reference range, but it's not far below. And so people who saw this in a table were much more alarmed. They considered it more urgent. They were more likely to indicate that they would phone their doctor or try to get in to see their doctor right away, whereas people who were given the graphic result were more likely to say, well, I'll talk to my doctor the next time I see them. The second recommendation is to signal whether differences are meaningful or not. And there are different kinds of differences that we might consider. So one of them is the difference between your result now and the reference range. And so one way to help signal whether the differences are meaningful are those number lines that I just showed you. Other kinds of differences include between this result and the last result, right? Because sometimes, things move around a little bit and it's not actually clinically meaningful. However, if you don't know that, it could be alarming. So using the full y-axis can help to display that, and techniques like possibly shading for expected variation, or even just directly telling people what level of variation is considered clinically significant may help with this. Recommendation number 3 is, when feasible, provide thresholds for concern and action. So this is a paper that we just published this year, and this took a very, very, very long time to figure out. So every time we did one of these experiments, before we even did the experiment, we spent a lot of time bringing people into the lab and doing user-centered design with them, and I'll talk a little bit more about what that is later. But basically, we bring people in and we show them prototypes of what the current design is, and we see how they respond to it, and then we make adjustments accordingly. So there were a lot of meetings, a lot of discussions, including with health professionals, to figure out the right wording for this. And the wording that we ultimately came up with was, many doctors are not concerned until here. And so what this did, adding this threshold, helped people to calibrate a little bit better what's actually a worrisome result. If you're outside the standard range, but it's not actually worrisome yet, you don't need to go to the emergency room. You don't need to get your doctor on the phone today. This is something that you'll want to follow up with, but you don't need to panic. So figuring out how to convey that was the focus of this particular study. And ultimately, this is the way we came up with it, was having these thresholds that help to indicate sort of the general consensus around this. And so we haven't published this yet, but we did a survey with physicians to sort of dig in a little bit about the medico-legal concerns about doing this. And I will summarize by saying that it could be possible to establish these thresholds much in the same way that clinical guidelines are established. And so I think these are the kinds of things that we need to consider as we go forward, as patients become more and more involved in our own care. So before I talk about the next one, I'm just going to sort of set the stage a little bit. So I showed you this earlier. These are my own results, and I shared with you that I have type 1 diabetes. So when I get my test results back, one of the first things I always look at is hemoglobin A1C. For those who don't know, type 1 diabetes is an autoimmune condition, and there was a trial that was done in the UK many years ago that basically showed that the recommendation that came out of that was that hemoglobin A1C for people with type 1 diabetes should be ideally kept below 7%. So that's generally the target for most people. When you're pregnant, it's about 6.5% instead. So anytime I get my test results back, that's one of the first things I look at. I look and see, oh, what's my A1C doing? And so you can see here that it's actually within the reference range. And it's quite a good A1C. In a different result, it was 6.5%, and there it gets marked as high. And I will tell you that as a patient, so putting on my patient hat for a minute here, this bothers me. Because the target for me is under 7%. And it is very, very hard work to keep your A1C at a reasonable level, especially when you have a stressful job and little kids and you have a life, and it's a hard disease to manage. So when I see 6.5% and it's flagged as high, that is annoying to me. I should be getting a good job, not a this is high. So that's sort of my personal view on this. And the fourth recommendation comes from actual data, not just my own personal opinion. But fortunately, the data backs up my opinion. I always like it when data do that, which is to individualize the frame of reference by allowing custom reference ranges. So what we found in this study was when we provide people with a range that is specific to the condition that they have, they responded better to their result than when using the normal standard or reference range. Because those ranges are not standard for every patient, nor are they the desired reference for every patient. And what we found was that the image on top, which is sort of a simpler view of this, was better. So the basic takeaway from this study was that substituting, so moving the range and making it very clear, this is the goal range for people with type 2 diabetes, rather than leaving the standard range in there and also adding the goal range. So the top one worked better. The bottom one is, you can see it's quite busy. There's a lot of data and a lot of information in that that's hard for people to take in. So this is the kind of thing where there could be default goal ranges for people who have a particular condition, and they could also be customizable. So these goal ranges could be set between the patient and their health professional. The fifth recommendation is to ensure that the system is accessible. And what accessible means is that all users can perceive, interact with, understand, and interpret, including when using assistive technologies. So assistive technologies would be something like a screen reader. So someone who is blind should still be able to use this system. There are guidelines for this, the Web Content Accessibility Guidelines. So if you're ever working with a web design team, make sure that they are following these things. We also need to consider health literacy, numeracy, and graphical literacy. So these are all different levels of ability and comfort with health terms, with numbers, and with graphs, if the system is using graphs. And I will mention here that when we talk about access, Often people think of access to the internet, right? There are absolutely a subpopulation of people who don't have access to the internet, who don't have smartphones, they're not going to use an app. And that is a really important issue because generally there's quite a large overlap between these people and the people who are most likely to have negative health outcomes. So the digital divide mimics health disparities. So this is an important issue. This is outside the scope of how we design a better online system, but it's always something to keep in mind. So one of the things that it was important in this work when we were thinking about accessibility was people who have color vision deficiencies. So about 5% of people who are male don't see colors in the same way that everyone else does. And so there are guidelines for how to choose your color palette and how to simulate what this looks like to someone who has these particular color vision deficiencies. The sixth recommendation is to provide conversion tools along with results. And this is because people, once they get their data, are going to use that data in ways that they want to. And this is okay. So imagine that a patient receives her total cholesterol and HDL in millimoles per liter, and she wishes to learn her 10-year risk of heart disease and stroke, so she goes to this risk calculator, except the risk calculator is asking for these numbers in milligrams per deciliter. Right? So for someone who doesn't know, who isn't familiar with these units, this has suddenly become extremely challenging. Whereas putting it right there in the tool when she's getting her results would be actually very easy. It would be easy to convert. The seventh recommendation is to design in collaboration with users. And I'm going to spend just a little bit extra time on this one. So this is a technique, there's a family of approaches that all sit under the umbrella term user-centered design. If you've ever heard the term co-design, that's part of it. These photos are from a user-centered co-design workshop that I held for a grant that I'm currently working on. So there are a lot of related terms to user-centered design. Can I actually just see a show of hands? Who has heard this term before? User-centered design. Okay, so there are other related terms as well. So human-centered design is often used interchangeably. The International Standards Organization document called it human-centered design. There's also a design firm in California called IDEO. They make a lot of stuff. They made Apple's first mouse, stuff like that. So they've really popularized human-centered design. There's also a term called design thinking. This term has roots more in business, and it's been popularized particularly by the design school at Stanford. Co-design, co-production, and co-creation, these are increasingly the preferred terms in some countries. So if you're from the UK, you've probably heard co-design and co-creation. And participatory design has roots in participatory action research, which is research that you do with communities, typically marginalized communities, and you are seeking to actually change something. So all of these terms, I'm finishing up a paper right now where we did a systematic review and looked at how are these terms used and what do people actually do. And all of these terms use very similar overlapping methods. And the differences really have to do with the disciplinary tradition, so where is this term coming from, and the location of power and responsibility. So co-design means you're sharing power and responsibility. You bring users in, and they are actually part of the team. They participate in making decisions about what you're going to do. Whereas some other methods, you are bringing them in to assess how they react to things, but the decision, the responsibility for making decisions rests with the research or the design team. So this is a framework. On the right, you see a framework that my colleagues and I synthesized from a lot of seminal literature in the field. And just a few key points about it. The first thing is that this is a process that requires iterative cycles. If you design something and show it to some people and get some results and then change it and then say, okay, we're good to go, that is not user-centered design. We did a Delphi study and found that minimum required number of cycles is 2 to 3, and it's really preferable to plan for at least 4 to 6. So if you're designing something, make sure you have worked in that you're going to do a lot of iterative cycles. The second thing is that when we talk about the user, often in health services research, it's very common to do a needs assessment. But what we care about for the user is a lot more than just needs. So we care about the user's goals, their strengths, their limitations. What context are they using this system in? What's their, if you're designing something for health professionals, what's their workflow? How is this going to fit into their workflow? What are their intuitive processes? How do they do this now? The third point is to prototype early. So if you're doing user-centered design, you should be very comfortable starting with paper sketches. Paper prototypes are a very acceptable, and I would say even a very good way to start. These are actual projects in my lab. And the fourth point is to observe, not ask. And this is a really key distinction, I find, for people in health research, because in health research, we're very used to bringing together focus groups of people and asking them their opinion. And that's good to do. You get good data from that, but it's not the same data you get from observing people using something. There's a famous quote that is widely ascribed to Henry Ford. If I had asked people what they wanted, they would have said faster horses. When you actually dig into this, there's no evidence that Henry Ford ever said this. However, it's widely ascribed to him, and it's generally agreed upon that it's the kind of thing that he would have said. So this doesn't mean that you should never ask people what they wanted, but something to think about is if people say they want faster horses, what you can take away from that is not necessarily that they want faster horses, but they want to go faster. That's a good piece of information. And the way that this happens is typically through user testing. And user testing, as I said, is basically just seeing how people respond to something. It's not asking whether they like it or what they think. And this is a really hard distinction to hold. But you see how people respond to things, and then you fix problems and adjust the design accordingly. And really what you're trying to do is find the problems as early as possible while it's cheaper to fix them. Because if you find your problems once you've already rolled something out, then it's a lot more expensive. You want your bad news here, not after your trial is over, your intervention is implemented. And the most useful feedback is the feedback you don't want to hear. More than once, I've had a project and had to just sort of scrap it all and go back to the drawing board. So what you're trying to do here when you see how people respond is to avoid problems like this. I see these a little bit less in Europe. However, these are all over North America, where you go up to a door, and it's got a handle on it. And what do you do when you see a handle? You reach out and you pull. That's the normal thing to do with a handle. That's what you would intuitively do when you see a handle. And the door doesn't move because there are handles on both sides, but the door only moves in one direction. So one of the founders of my field is Don Norman, and these kinds of doors are actually called Norman doors for this reason. They are so annoying. And it's just bad, it's a bad interface, because interfaces should be intuitive. I love this quote. A user interface is like a joke. If you have to explain it, it's not that good. So your interface should be intuitive for people to use. And this is what user testing helps you figure out. So, and what you're going for with user testing, there are 5 metrics for good systems. Good functionality, meaning that your system works. It does what the design specs say it should do. You're going for good usability, so it's intuitive for people to use. Accessibility, which I mentioned earlier, which means most or all people can use it. Good user experience, which is related to usability, but it's not quite the same thing. It's about how people feel when they're using it, which matters, because if you want people to use a system, you need to care how it makes them feel. And good implementability, so it's feasible to implement this system in the intended context. And the key point about user testing is that you're not getting at all 5 of these, but you are getting at these 2 particularly, usability and user experience. So that was my little mini bit on user-centered design, which is something I care about a lot. So the 8th recommendation is to design for both new and experienced users. And this is tricky, this is not always simple, but you need to think about people who are coming to see their results, their lab results, and one person is an older gentleman who has just been diagnosed with something. He's never looked at these lab results before, he doesn't know what this number means. And the other one is a middle-aged woman who has lived with this chronic disease her entire life, and she knows what these numbers mean, and she doesn't need all the intro 101 level information. And so there are ways to do this, and one of the speakers yesterday sort of gestured to this, talking about hyperlinks. That is called layering your information. So what people see as a default is just the basics, But you give people the possibility to dig for more information by layering it. Another thing to do is to have onboarding for people who are new to a system. So if you've ever installed an app on your phone and you get those like 4 screens to sort of introduce you, and there's a little arrow saying click here for this, and that's called onboarding. Sometimes it's done well, sometimes it's done less well. But when it's done well, it really helps to orient people to a system that they haven't used before. And the third thing to do to help design for both new and experienced users is to allow people to set their settings so that once they're used to a system, they don't have to see all the introductory explanatory stuff. The 9th recommendation is to make it easy for people to use the data as they wish. And this is really about supporting user choice and innovation. So on the right here, you see a photo of what's called an open artificial pancreas system. So this is one of the goals in type 1 diabetes, is to have an artificial pancreas that will connect a sensor, a continuous glucose monitor, to an insulin pump. So right now, someone mentioned this yesterday, they can send the data to the pump, but so far there aren't any systems on the market where that is a fully closed loop and the pump will think for itself. However, there are over 100 people who have built their own. So this was a system that grew out of something that some parents of children with type 1 diabetes built. They hacked basically how to get access to the data that were coming out of these sensors, because their kids were at school wearing these sensors and they had no idea what their kids' blood sugar was, and the teacher wasn't very helpful, and so they hacked this system to send the data to the cloud and then back down to their phone so that they could keep an eye on their kids' blood sugar while they were at school. And from there, a number of systems came out. And the people who built these systems, maybe they foresaw this, maybe they didn't, I don't know, but people will do things with data that you had no idea. And this should be supported, because really the goal is to help empower people to do what they want with their own data about their own health. This is another system where data can be combined, and people can only use this kind of system if they can get their data out of a given system and bring it into another system. So data needs to be portable. And the 10th and final recommendation is to collaborate with experts from relevant fields. So there's a lot of expertise out there about how to do these kinds of things. There are experts in health communication, in psychology, in designing patient materials, in human factors and human-computer interaction, in user interface design, user experience design, information design, including data visualization and graphic design. So I will add one note of caution about those last 2, which is that there is an ethic in data visualization to make things pretty, right? People like to see things that are really, really lovely. Someone yesterday mentioned Tufte's work, and Tufte is one of the pioneers in data visualization, and some of his principles are very, very good, and some of them are a little bit problematic because they make everything lovely, but they actually make it harder to use. So the goal is always to make things useful, even if they're not always as pretty. So with that, I leave you with these key takeaways, and I welcome your questions. Thank you for your attention. Oh, what happened to my takeaways? Can we leave the takeaways back up? I guess not.
Thank you very much. This was fascinating, and we learned a lot from you. Thank you. And questions now. Yes, please.
Thank you very much for a nice presentation, and I have one question: how to combine the laboratory data with other clinical data? Because for patient, only laboratory, it's not enough for understanding normally.
I'm sorry, can you repeat the question? So as I understood it, tell me if I misunderstood. What you are saying is that the laboratory result itself is not enough to make it information. Mm-hmm. Yes, I would agree with that. Whoa, can we go back? We can't go back. Can we back up? I know. There we go. No, we're going forward. I have no control over this. All right. So yes, ideally, laboratory results are not a standalone system, right? Ideally, this is part of a patient portal to an electronic health record where people would also be able to do things like click for more information about heart disease, click here to send a secure message to your healthcare team. There would be patient navigators and so on. That is part of a larger system. I would agree. But I also think that it is possible to have brief explanations of what is this test for? Why is it often done? What do these numbers mean? That could be done, right? And if we provide people, people who are viewing their laboratory results in a patient portal obviously have internet access. And so if you provide them with the right words to use, they can seek additional information as well. I don't think it's easy. I say this like it's easy. Oh yeah, it's not easy. This is not simple to do. But this is the kind of hard work that needs to be done. You know, I don't think this is optional in 2018. I don't think it's optional whether or not people want to do this work or not, this work has to get done.
Thank you. Jonathan.
Great talk. Thank you very much. I just want to push that same point about clinical context, whether it's either for professionals or patients. I don't think we're going to get very far if we have a system that has to display your glycated hemoglobin without knowing deeply in its design that you already have type 1 diabetes and have had it for some time. So that the elements that you show can be redeployed, but they're going to work, they're going to be much more contextual. For example, the reference interval for a healthy population becomes totally irrelevant once you know this patient is not a member of that healthy population. So I very much agree with you that we need much more scenario-based research, but it is going to be more complex to get that context in. The elements you've shown will be the ones that are redeployed. But there's a much deeper question, and that is you're showing a small number of results. In patient care, junior doctors are seeing a large number of results with no context, with lots of context, but no hypotheses. They're just trying to get through them and deal with them. Do you think it's even possible that with elegant design, we're going to do that, or do we need to use artificial intelligence decision support to get rid of a large number of them so that the ones that are carrying new information can get through the signal-to-noise problem?
I don't know whether it's possible to do it without artificial intelligence. I don't see why we wouldn't use it at this point, right? I mean, there's a lot of potential there, and I agree. I think one of the great potentials of artificial intelligence is to help to sift through and sort of elevate, okay, these are the things that the human should pay attention to, right? So I mean, whether or not it's possible to do without, I don't know, but I don't see why we wouldn't use these methods that are very exciting and have a lot of potential to help sort through and essentially reduce the cognitive load of the user in these situations. I don't know if that answered your question.
Danielle is first.
Yeah, hi. I'm Danielle Friedman. I'm chair of Lab Tests Online UK, and I'm a bit disturbed that you didn't mention Lab Tests Online. I know in Canada, do you have Lab Tests Online? Why not?
I don't know.
Exactly. So that answers your penultimate question. Mm-hmm. That's what Lab Tests Online is for. It's for mainly for patients and carers, but we know for a fact in the UK that 40% of people that go to the website are healthcare professionals, which goes back to Jonathan's point, because he's also on the board of Lab Tests Online UK, and I have Patricia Wilkie somewhere, who's also on the board of Lab Tests Online UK, that 40% of people that go to the website are healthcare professionals because they don't actually know anything. Yep. So why, just answer my question, why in Canada do you not have Lab Tests Online?
Well, she's not from the board. As a patient, maybe. Yeah.
Because I don't yet run Canada. No, I mean, very seriously, I mean, I'm kind of joking there, but the healthcare system in Canada is essentially, we have 14 different healthcare systems. There's one province that has a pretty decent electronic health record. None of the other provinces are there. You know, I don't think there's any good excuse for it, really, but we're not there. I think one of the points that you're raising and that Professor Kay was raising as well is basically another point that, I mean, I was asked here to speak about patients, but health professionals are humans too. We're all human, and people who don't have the expertise in a particular area, everyone benefits from having things presented clearly and in a way that helps humans understand them and turn data into information, into knowledge.
Okay. So we have time for 2 more questions.
Thank you for a very nice presentation. Unfortunately, in Denmark, we have this portal where we are using cumulative laboratory report for the least 50 years. I'm just wondering, as Professor Kay has also stressed, if you have some information model behind your interface, because putting all these information attributed to the test result would be very, very good, but it needs somehow information model. So are you thinking of something like that?
Yes, yeah. No, that's a very good question. So the question is about essentially what's on the back end. How do you figure out what these ranges are and so on? So I'll be very honest. As a person who works in interface design, as far as I'm concerned, that comes after. We figure out what's useful to the people first, and then we figure out how to do it. Yeah, I'll just leave it there. We can talk more later. There are definitely ways to do this, and there are information models that can contribute to this. But I think this was raised earlier. This is a complex issue that's going to require either a lot of human time or some advancements in artificial intelligence to be able to determine what some of these values are.
Last question, please. Sorry, behind you. Yeah.
Thank you. Understanding of test results by patients is very important, but on the other side, how about clinicians? Can we say that really clinicians also interpret test results correctly when they use population-based reference intervals? I am not sure. If we ask the same questions to clinicians, because we know that the interpretation of test results by clinicians is one of the main source of errors. Unfortunately, this is a reality. I have a project and have some preliminary data about the interpretation of test results by clinicians, particularly about the variations. Most of clinicians are not aware about the variations of test results, especially when they monitor their patients. I'm not so optimistic about the clinicians, even clinicians.
Yeah, so the question is about do clinicians understand test results either, and what do we need to do to support them? This particular project, so I was asked to speak about patients, but as I said earlier, I think that we have good data that clinicians have many of the same biases and heuristics and lack of understanding as the rest of us humans. And so the kinds of techniques that help patients better understand are likely to also help health professionals better understand. I mean, we know, we see this in other contexts as well. So for example, in the same way, putting something in plain language helps everyone, including people who are supposedly experts in something. Everyone benefits from plain language, not just people with low literacy.
Thank you.
Thank you.
Molly. We let you go now.
All right.
Sorry about that. I'm sure there are many questions people would like to ask from you, so in tea time I think that's a great opportunity to do so. May I now introduce Witte Osterhaus, my long-standing friend and ally in evidence-based laboratory medicine, who is going to tell us more about interpretive comments and how they will transform not just data to information, but information to knowledge and wisdom. So now, Witte, we are ready for your wisdom.
Thank you, Rita. Okay. Well, we have heard a lot about artificial intelligence, about doctors, maybe just a question, not possibly not quite understanding laboratory results. There are a lot of challenges, and I want to take a step back first and see where we are and how to proceed from there. Well, we can go back 20 years here, and already it was recognized this issue of translating our data to knowledge and to help our doctors to understand the test results. And that was in a time when labs were merging. Well, we are familiar with that still. Larger scales, a lot of data, and we should come out of the corner of only generating numbers. And well, people came together and thought about this, and all the vision then pointed to in the same direction. We should not only provide numbers, we should add value to these numbers. And even to a point that it was questioned, it was rather provocative, that we may not survive as clinical chemistry. Well, as we are here with a lot of people, we are still there, but it was the same thing, pointing to in the same direction, add value to these test results. And also in the Netherlands, we had a 5 years plan. We should also move in a direction from doing only the tests to mingling with the doctors and adding value. And it resulted even in a guideline I was involved in consultation. And I'm talking about consultation on a regular basis, not waiting for the telephone to ring, but being proactive. And if we look at ISO, it's even there. It's part of our profession to do this consultation thing. And a very recent paper from one of the working groups of IFLM, it's also, again, in the same direction. So we, as a laboratory field, we feel that we should work on this consultation thing. But are we really doing that? Well, let's look at this. We talked about needs assessment. Let's go into a little bit about this needs assessment. Is there a need out there? Or are we only thinking that this is important for us? Maybe these doctors say, well, mind your own business, give us the numbers, that will be okay. Well, we do something about reflex testing, I think everyone does. This is something that is high volume. This will add a little bit to the only numbers. It can be automated, so we do that. And colleague Lippi made it more sophisticated in diagnosing or excluding heart attacks. Reflective testing is a means to organize and proactive do the consultation. It's adding tests, it's adding comments. It was introduced in about 2004. Well, if you don't know what it is, if you have an unexpected result, abnormal result, you might add, as a laboratory, some tests, in this case to exclude hemolysis, and then you might add a comment and a conclusion that it might be a benign hyperbilirubinemia, Gilbert syndrome. Well, there were a lot of papers on this reflective testing and show that it could be valuable. This is another means that we want to introduce in the very near future. The 1st of August, we want to start this as a sort of reflective testing on demand. So the doctors might tick this box, and then we will look at their lab results, and they are asked to add a question or what the problem is. Well, this is also a sort of needs assessment that has been done in England, in the UK, and they asked, what do you want as a doctor? Do you want to add tests by the laboratory or phone, or add a comment, or do nothing? And what you see here is that doing nothing is the least preferred by the doctors. Okay, and we did the same in the Netherlands with the same result. Again, pointing to in the same direction. Doctors do not want only numbers; they want an explanation and added value. So there is a need out there with doctors. And we just very recently, these are some preliminary results, for specialists. We wanted to know if specialists the last slide was about general practitioners, and we wanted to know if specialists had the same opinion. And here you see the same thing, that results only is the least preferred option. And they want comments, or these are all clinical cases, and we give an example of reflective testing. And this is preferred, comments. Maybe sometimes they want to be phoned before, but in most cases they do not want only the numbers. So there is a need out there with doctors. And we looked into, this is an old study we did, is there any added value, this is an outcome study. And we see that even we could, with this panel evaluation, we showed that there was an improved quality of care also. So it's not only a need, it's an added value in improved quality. Now about patients. What is the need assessment in patients? And they also have no problem with a laboratory adding tests, as has been shown. And another thing that might even change the whole field is that patient will get their results. It's inevitable that with all these patient records being available, they will get access to their results. And as just has been explained, they will not understand these results. I think it has no use to communicate just the numbers to the patient. And in the Netherlands, this is a project that by 2020, all the patients will have access to their data, to their medical data. And 100 million euros has been provided by the ministry for all hospitals to get this done by 2020. Okay. And well, this also points to the same direction. Patients will get access, but won't understand the results. So, we did a sort of a short trial with 40 patients, giving them the lab result, including an explanation in lay language with easy to understand comments and conclusions. And the question was, is it possible to make this understandable and do the patient like this? Well, as a shortcut, it was very much liked. Almost all patients like these reports and want to have them again. But this was done by hand, so of course it's impossible to do this in a larger volume. So we have in the EFLM the patient-focused laboratory medicine working group, and we also did a survey on a larger scale of patients like this, and it's again the same conclusion. They like this, they want to have it, and they think the laboratory, as far as they are specialists in this field, are accepted to give these comments. So there we are. Doctors want it, general practitioners want it, patients want it. We think that it's a very good thing to do, but are we doing it? And do we have an answer with these large volume laboratories to really proactively comment on all these test results? I think we don't have an answer yet. That's the problem. That's the challenge. And another problem is that in our laboratory we comment on hematology results, and one colleague makes very short comments, another long comments. So also in automating this, you have a harmonization of this commenting. So what is out there as solutions? Well, again, you have to look back. A lot of techniques and statistical techniques have been used, and well, you might recognize some of them, multivariate analysis techniques, but these are very complicated. There have been some expert systems, all systems that need large databases with calculations are also difficult to transfer from the one laboratory to the other. If one test changes, you have to recalculate everything. That makes it very rigid and difficult to apply. Well, there have been a lot of papers about this. These papers are becoming less numerous. The last years, I looked for them, 46 now in 2017. So there have not been really many applications for these very sophisticated systems. Well, you all know this application, but you all know that to apply this, you have to have very well calibrated tests. Only certain labs can do this, at least in the Netherlands. I think there are 5 laboratories. So it's difficult to apply these multivariate methods. It's not easy. So are there any new techniques out there that we could apply? Yes, there are some. These are rule-based systems that are more easy to handle and adapt to your needs in your laboratory. One system actually from the Netherlands is applied on a wider scale for drug-drug interactions in a pharmacy. And we are now working on an application for drug test interferences and to automatically generate comments when there is possibly an interference. That we all know that some drugs change your test results, and that might be an explanation for the abnormalities you see. And this is a system that we try to get working now as a proof of concept in 5 laboratories in the Netherlands. And then a comment will come on your report and alarming the doctor that the results might be abnormal because of the drugs used by the patient. It's very complicated because you have to link the database of the medication that has to be available. You have to have a database of all the patients and the drugs they use, and the test results, link them together in a special system and apply some rules. But it's now working in 1 hospital in the Netherlands. Another system that might be a solution is a ripple down rules. Ripple down rules can give more than one solution or true value. It's not a decision tree that ends in one decision, but might lead to more true decisions at a time, and it makes it possible to create comments. For instance, if you have a microcytic anemia with also a component of inflammation, it might make several rules true, and you can compose a comment based on that. And this is working. This is an Australian system, And the new thing is, and one of the messages I want to bring across here is that now large firms have identified this possibility and support this possibility. It's Philips that has linked this system to their LIS, and there are a few laboratories in the Netherlands that work with this. So it's working, and the link between your LIS needs to be rather sophisticated, because the system can give a signal that tests should be added and also that comments should be added. So it's a bidirectional connection, and also historical data are used. So it's looking back. And also, and it's a bigger initiative, I have no connection with any of these firms and no interest whatsoever, only that Abbott wants to do a project together with, the EFLM working group. We are now discussing this as a possibility. Abbott also works together with this PKS Australian system and, sees the possibilities and wants to do a proof of concept trial. So these might be possibilities. But again, this is how it works. You link it to the LOAS and reports can be linked to your system. So my message here is clear. If you look at the needs assessment that we talked about yesterday as a Western thing, the need is definitely out there. The doctors want it, the specialists, general practitioners want it, the patients want it. The patient will get access to the records, but will not understand our numbers. There are some solutions out there, and I think all these statistical systems are very complicated and impractical. Rule-based systems might be more flexible and easy to use. Big companies are now seeing the possibilities. So we should act on this and make it work. That's my conclusion. And that's the way to go from chemical to medical and really do it. That's the challenge. I thank you.
Yeah, two, please. The first one is, you've got really good information on what people would like to see out there, but we're not making a lot of progress on changing things about how this is. No. And the first one is, there seems to be an assumption, and that showed in that Abbott slide, that the only information available to the person adding value with interpretation is what's contained on a request that's associated with a specimen. That's never going to be enough to create high value. So as clinical information systems become computerized, what do we know about how much better we can do from a laboratory frame if only you had access to the entire records? At the moment, I've only got anecdotes on this. I've got microbiologists who say they can add much more value by seeing images of a patient. They're never going to be included with a particular request, but that it takes longer to do it well. Now, whether you have access to that clinical information or not is an artifact of the organizations you work in. Is it the same organization that's seeing the patients? Is there a split between primary and secondary care? Are you a private laboratory that isn't allowed access to those records? Has anything come up in these studies that show that you can give more value in interpretation if you're not limited to the information on that or maybe previous requests?
Thank you for your question. Well, this is a comment that has been, I have heard more often. You cannot comment or give valuable comments if you don't know the clinical situation. That was what general practitioners said when we did trials on commenting on patient results, and that is a comment we often hear. The point is that even if you don't have so much clinical information, you can add value and make an interpretation as long as you don't go too far, as long as you only address the information that is in the laboratory results and don't make any assumptions. And it is my conviction that it can be done. We have been adding comments on laboratory results for years, and all I see is the laboratory result, maybe historical data that are in the LIS, and that in most cases that is enough to come to a reasonable comment. So I don't agree that you need to know. In complicated cases, yes, but in cases for general practitioner patients, it's more than 90%. You can give a reasonable comment without knowing the question.
Okay. Any other questions, please?
I just don't know whether Jonathan got the answer he might have wanted, but I'm the data protection officer now for 400,000 patients in the northwest of England and 80 general practices, and I'm just signing off a data sharing agreement for out-of-hours services, ambulances, hospices, and other organisations to have access to patients' wishes for the end of life. Now that is a legal information governance approved document, which means we can share data across those organisations. We're also doing the same for patients who need multidisciplinary team assessments, people who are frail and old and elderly. And as a data protection officer, I'm signing that off. I can see and envisage that we could manage to allow laboratory physicians, as long as we do the appropriate information governance and we have the appropriate agreements in regs, to make the general practice record available each time with the patient's consent. I don't know if this is what Jonathan was driving at, so that actually, if you wished, I'd be very happy for laboratory physicians to be able to see the record at the same time.
Thank you.
Okay.
More comments? Yes?
I like the talk. When we compare it to the first talk, you are adding value from the data you have. The danger from the first talk was that we are personalizing the reference range limits, but there's the chance that we make mistakes when you're personalizing it too much. In your concept, you take the data you have and personalizing the comments to the patients. And so if you don't have comments, there's still a rather valid test result we give to the patients. When we go the other way around, there's the danger that, for example, if I have a creatinine of 3 milligrams, in my situation, that would be acute renal failure. In the older patient, it might be just decrease of his renal function. In your situation, you know that I was healthy until yesterday, and you will tell the doctor that there's a high risk that I got acute renal failure. You get the concept? It's like bottom-up and top-down concept. And I think your system is far superior to the idea of personalizing it too much. Thank you. Did I confuse you?
Okay, thank you for this comment.
You can take it as a comment. If you, yeah.
Okay.
Yeah. All right, next question.
What about an obligatory global conclusion at the end of the report? What about, in your opinion, an obligatory conclusion at the end of the report? Not only specific test explanation, but a global conclusion.
Mm-hmm. A summary report,
yeah.
I think.
A summary report?
Yeah, a summary of the total picture, not just at each test, if I understand well, but a summary report of the complete picture.
That's what we did. A summary. Well, for the patient, the trial we did, we commented on each test separately, and if there was some important pathology, we gave a conclusion linking these results together. That was the idea.
Ken?
It's Ken Sakaris. I'm from Australia. I belong to a very big company, Sonic Healthcare, and in Australia we own primary care networks as well as primary care computers. Mm-hmm. So for us, the idea of a pathologist getting out of the laboratory is not to put comments on reports and get out of the laboratory. It's for pathologists to play a role in the clinical software. so that when the request is being made, we get all of the relevant parts of the history at the time the clinician can gain patient consent for passing that history if necessary. So that's at the front end. And then at the back end, when we've got an interpretation that needs that clinical insight, this is a sort of a realisation that I've had. The best place for that interpretation is to send the numbers to the clinical software and make the interpretation there. Because really we don't have that information to create the intelligent comment within the laboratory. And so, you know, I see that is the future in digital health, is for the laboratory experts to get involved in the clinical software, not to see this as a game of the laboratory software.
Well, I agree that interpretation would improve, if that also is what you mean, would be improved if you have more information. But I also, my experience is that if you have limited clinical information, you still can add value to the report.
All right, too many questions. Now I give you the opportunity because last time I didn't. So.
The first speaker and actually also the second speaker present examples in which the interpretation emanates from a single point in time, but we have within the laboratory consecutive results of a single patient. The longitudinal representation of these data, just a representation would contain a lot of information. Did anyone experiment with longitudinal reporting?
The ripple down system does include historical data, and also these are used in the interpretation. Yes, that's possible. That's integrated in the system. Yes.
Okay. Mario.
Just a short. Our experience in pharmacogenomics. Okay, so we perform some tests that show the differences in activities of some enzymes metabolized in chemotherapeutics in cancer. And in order to, how I say, facilitate the acceptance of this test to the oncologist, we divided the report in two parts. The first part is performed by from the lab, who makes evidences, for instance, the presence of a certain polymorphism in the gene sequence of that gene. Okay. The second part is signed. The interpretation of this result, analytical result, is performed by a pharmacological oncologist, who says, okay, on the basis of this polymorphism, I suggested to, reduce the dose of this chemotherapy, this drug, to 50%. You understand that the impact of this decision, it's so important for the patient, also for the decision for the oncologist, that I don't know if we have the authority in terms of clinical chemistry lab to make such an important consequence for the clinician. So that's why we decided to find out another, I would say, expert who eventually takes the responsibility to suggest the reduction of these doses.
Yeah.
Okay.
Okay.
I think we will have to discuss it maybe in the panel discussion, because that's quite an important question. So thank you everybody for the questions. Thank you. Witte. We have to move on.